I'm Dr. Daniel Brown, Chief Medical Officer of Meridian Healthcare. The American Congress of Obstetrics and Gynecology and the American Society of Addiction Medicine have a joint statement regarding the best practice for treating women who are pregnant and have opiate addiction. For a long time, we've treated pregnant patients who have opiate addiction with medication-assisted treatment over medically monitored detox. The reason for the preference for medication-assisted treatment, there are several reasons. One is there has been a reported risk that when mom is put into a detox program, the baby also has to go through detox. The baby also withdraws, and it can cause some fetal distress, which was believed to lead to preterm labor, premature birth, miscarriages. Recent evidence doesn't support that as much, that it may be a little less risk with that than we thought in the past. But we do know that even if you can detox mom and you can get her through, through that physical dependence, unless you're controlling her environment, there's a high risk that she could relapse by the end of the pregnancy. Moms who relapse or moms who continue to use during pregnancy are at risk to have babies who are born premature, low birth weight, a lot of things that once they're placed into a medication-assisted treatment program will improve. So a mom who is treated with medication-assisted treatment, either methadone or buprenorphine, birth weights tend to improve and to rise, and the risk of premature birth declines. Medications used for medication-assisted treatment for pregnant women include methadone, buprenorphine, and also naltrexone. Naltrexone is Vivitrol. So for a long time we used methadone almost exclusively for this because we had a long history. Methadone's been around in treatment of opiate addiction and used with pregnant women with opiate addiction since the 1960s. So we had evidence to show that it worked, that it improved outcomes, that it was safe, and that there were no long-term effects as far as the baby down the road. But what we found is that when mom is on methadone, methadone is a full agonist medication. It's the most powerful medication we have. It works well, but we find that the baby has to withdraw from it longer than they would from some of the other agents that we have, such as buprenorphine. So recently, the preferred medication that we've been using is buprenorphine, also known as Subutex. It also can come in the form of Suboxone. Suboxone is buprenorphine plus naloxone in one medication. We tend to use the mono product, which is the buprenorphine by itself for pregnant women, so that the mom isn't exposed to the naloxone unnecessarily. But really there's very little risk associated with that, and using Suboxone or Subutex is generally considered appropriate in either case. Buprenorphine, what we find is that moms who are stabilized on this medication, we see the same benefits as we do with methadone, improved weight gain, improved reduction in premature labor, premature birth. And generally what we really see is that the neonatal abstinence syndrome, the withdrawal phase for the baby after it's born, is much less than with methadone. And so that has become the preferred agent. Naltrexone, which is Vivitrol, is also used. The problem with naltrexone is that you would have to detox a pregnant patient off of opiates before you could put her onto the Vivitrol injection or give them the oral naltrexone. And so you would have to place that mom through that detox that we have concerns about the effect on the baby before we could get them to the injection. So the only pregnant women who are on naltrexone in our programs are ones who are on the medication prior to becoming pregnant. We have continued that medication and have seen results with that.